All right, terrific. Thank you. Thank you, everybody, for joining us tonight. The focus of this talk is on monoclonal antibodies. We put out in there was some conversations in our doctors chat network about whether it's a good idea, bad idea, what the data shows. So we were able, with the help of Jack Hittery, to organize Dr. Shatkis from Mount Sinai, along with Dr. Bander, as well as Dr. Medeb, all three having firsthand experience using monoclonal antibodies. Jack has also been working diligently on making these treatments available easily and locally. It's really all he's been working on. So at the end, we will be able to share with you some contact information if you do decide it's suitable for some of your patients, what's the best way to get your hands on the doses and to get people scheduled, trying to make it as frictionless as possible. So at this point, I want to thank the doctors on the panel for joining us. I'm going to hand it off to them, and thank you for everybody who's come to hear from them. So I think we're going to Dr. Shatkis first, correct?
Thank you, Jeff. So I guess the key takeaway point for tonight, if we were to summarize this very briefly, is that for your patients who are early on in their infection, they have recently become symptomatic, monoclonal antibodies are what you should be thinking about for those patients, specifically in those who are the highest risk. The emergency use authorization, and that should be clear that monoclonal antibodies are not an approved therapy, they're an emergency use authorization because the data is only short term, but there's enough to suggest that this is beneficial, is for patients who are of the highest risk. And that, according to what was put out by the FDA, that is patients over the age of 65, any patient that's a diabetic, any patient with kidney disease, any patient that's obese, and that's a BMI over 35, patients who are 55 and over that have coronary disease, high blood pressure, or COPD. And then there are some criteria as well for children that have specific diseases, that's ages 12 to 17. And I believe the information is made available at the end of this for any providers that want to see it, or you can look up online the specific FDA EUA. There are two products, but with that, why don't I also transition over to Dr. Bander if he wants to talk a little bit more about the products themselves and how a little bit about the infusions themselves.
Yeah, I mean, just background for all of us who treat COVID is all physicians on here, right? It's sort of, I always say it's a Russian roulette, even in terms of people who have the risk factors, is that you have plenty of people who have or elderly, have diabetes, and they get COVID and they have mild disease. The problem is that you don't know which of those patients are going to get sick. So that's why, it's really important early on to try to get as many of those people in for the monoclonals, because you're trying to prevent the one that has that risk factor that's going to progress to that significant inflammatory phase. I think that one important distinction we'll make tonight when we talk about antibody therapy, we're talking about monoclonals are for outpatients only, and they've actually been shown to be effective only in patients, outpatients. All the studies so far that have been published have shown that once you're in the hospital and you already have an oxygen requirement and you're sick, they're actually not beneficial. In fact, they actually had a signal for harm in some of the studies. So this is something that, it's a little bit of, you have to convince people because you're getting them at the stage before they're sick. So, people think they're going to get over it. You have to be convincing them that this is the time to get it before you're actually, ill. So we can go over a little bit, Josh, in a minute, some of the data for it. What are we talking about? What's to prove for it? I think what you're right about with COVID is that, this is an EUA, right? If you look at the infectious disease societies, they don't actually recommend it. They're saying there's not enough data because all we have are early phase 1 and phase 2 trials that are, promising, but nothing that would meet, the criteria of a randomized controlled trial. That's why they're all approved under emergency use authorizations, because they don't meet the traditional rigorous academic studies to say they're beneficial. They've been followed for a long term, but definitely that's why what it's based on is why it was thrown out to the market pretty quickly.
Dr. Bender, I think you had some slides.
Yeah.
You want to share?
Are you able to see my screen?
Yes. You want to maybe go to full present mode though on the lower right.
You mean in
Yeah, lower right-hand corner, the little, yeah, that little guy. There you go.
okay.
Yeah, that's great.
I mean, Josh, you're seeing the screen. I mean, you basically said, I mean, the criteria are long, but basically it really comes down to is anyone over 65. That means if you're 65 and healthy, you meet criteria. And that's because we really don't know, even if you don't have diabetes or any other condition, older people tend to have the course, right? If we look at statistics, the vast majority of deaths, vast majority are in the people who are in the, in the older subgroup. And then it's basically anyone 55 or older who has hypertension, which is a good chunk of people, or cardiovascular disease, COPD, or any autoimmune disease really, would have it. And sometimes it's a matter of, having even pre-diabetes or anything like that. It's how you fill it out. But basically anyone who's at risk would be qualified under that. Now, I don't think I haven't given to any kids. I don't know if you, Josh.
No, I haven't. And
I haven't seen any. I mean, I've given to some. Youngest person I gave it to was 18 with a single ventricle, and that was about it. But if we look at the data for these, remember that these studies are the two companies that Josh had mentioned, Regeneron and Eli Lilly. Basically for Eli Lilly, and this is the first drug that came to the market. I can't even pronounce it, even though I've said it a million times. Josh, you want to pronounce it?
Bamlanivimab.
Very good. So
Before we just say BAMLand for short. BAMLand.
Yeah.
By the way, for the purposes, what we've been told as providers is that for the purposes of your patients, that these are equivalent. They're being used depending on which facility you go to. They're just being used interchangeably. Some facilities are going to have both. Some might have one. But as far as I've been told and what I've been taught is that these are equal. So as far as I know, there's no reason to request one or the other at this time, and facilities are using them interchangeably depending on what their pharmacy has access to.
So yeah, we're continuing to a little bit. The Eli Lilly product contains one monoclonal antibody. Basically, they took these antibodies. They took patients who were convalescing, and they looked at their antibodies, and they found the ones that were neutralizing. And what that means is how these monoclonals work is they bind to the spike protein on the virus to prevent it from binding to the cell. So the idea is, one, that these antibodies will prevent the virus from binding to the ACE2 receptor on the cells and prevent infection. So for people who are newly infected, the virus is circulating, basically knock that out of circulation. And the other part where it works in patients who are already sick is it helps induce the host-mediated immune response by activating binding to the viruses and activating clearance with macrophages. So really, there's a third one, but that's the general thing here. We're trying to knock the virus out. So when they studied these patients early on, what they looked at, this is what the data is based on, is they took patients who were symptomatic and they gave it to them within the first 3 days of a positive diagnosis. So it's when they were tested. And the median time of being sick was about 4 to 5 days in these studies. We're not talking about patients who are sick for 10 days, which is what the EUA says, but most of these studies were conducted really early. And the reason why I'm driving it home is because that's really when these drugs will have the most benefit. So you look at the Eli Lilly drug, they took 465 patients. Of those, there was only one adverse reaction out of all those patients that had anaphylactic reaction. And what they were looking at was reduction of symptoms by 2 days, 8 days versus 6 days. What they were actually looking at was reduction in viral load using different drugs. I don't think it's that important to go through it. But what I think is important to really mention here is that patients felt better. It reduced their viral load and their symptoms. But what's most important is looking at events, right? So in the arm, 156 patients received placebo or did not receive the drug. Another 300 or some odd patients received different doses of monoclonal antibodies. Now, of patients that didn't receive the drug, 6% had were admitted to the hospital or had events versus only 2%. So you have a pretty significant reduction in the amount of patients at 28 days that end up presenting to the hospital or being admitted. There's no mortality data here. It's just admission to the hospital, morbidity, and decrease in disease. Eli Lilly was similar, 799 patients, 3 days positive, also only one reaction. again, the endpoints here was actually, in reality of the study, was viral load, how much viruses these patients had in their nose. And again, what was important was the patients who received this drug had symptoms decrease much earlier, and as well, they had, about 50% reduction in events. We're talking about a very small number of events. That's because only small percentage of our patients who get COVID progress to go on to the hospital. But it's really these patients that we're really trying to get to, right? So that's why, it's not reducing mortality by 50%, but if we're hitting those patients that are going to get sick, that's where we find the most benefit. So if you look at actually the subgroup of these patients that were elderly, BMI greater than 35 or 65 and older, you had a 16% event rate versus 4%. So there's definitely significant reduction in hospitalizations and ED visits and care required. None of these were powered to look at death or mortality because these are early on. Those studies are still ongoing. So if it's sharing it's physician to physician, I want to tell you what the actual data is. So this is really just 2 slides. I'm not going to kill you with the rest of the data, but it's safe and it's effective reducing viral loads, symptoms, and presenting patients going into the hospital.
Let's just stress that point there for a second that Dr. Bander just said. We're speaking physician to physicians. I believe Jack targeted physicians here, and that's an important point. Is at least the institutions that I know about, this generally has to be through your physician. This is not something where a patient can just say, I want to go get the monoclonal antibodies, and they can go and get them. And so it's really important for providers to understand that this therapy is available. Try to find out which I don't know where everyone's from here that's listening on this call. Find out what institutions are near you that have this available as a therapy. Some of the places have less or more than others. And so knowing who might have now, might not have tomorrow. Those are really important points. And then I wanted to just speak from personal experience. I think I've probably at this point referred about 30 patients, I'm just estimating, for this therapy. As far as to my knowledge, not one of them has ended up in the hospital or ended up having a significant reaction or a progression of their disease. I'll ask Dr. Bander, and then I believe Dr. Medeb is also on here to talk about his experience with referring patients as well.
I've had 2 patients that received the Lilly product and then were hospitalized out of about 100 patients that we kept track of so far. So overall pretty effective. And those people were looking at what strains of the virus they have. As far as we know, this is effective against most of the strains in the U.S. There were some questions about some of the new strains in England, whether it's effective or not. But for what we have here now, it's the monoclonals are effective.
Dr. Medeb, do you want to talk about your experience? I believe you've also been using this therapy for your patients.
Sure. We've already given it to
Dr. Medeb. While you're speaking, Dr. Bender, do you mind going back to the inclusion criteria? Because it might be good for Dr. Medeb also to go into a little more detail on that after he shares his experience. Go ahead.
We have been doing this for the last about 3 weeks. It was highly allocated to us in the beginning. We didn't have too many. I think we're up to about 50 patients. About 50 to 60%, I administer them to myself through the emergency department, which is what we're doing. I think a big problem is that the doctors don't really understand in the community that the whole purpose is to give it early, except like Dr. Bander was stressing. And I think that's a bigger, they feel great. Today I got a call and I was speaking to Alan Esses on it, that they don't realize that, that now they're calling, there's this little window between 3 and 7 that people feel like let them stay home. And they're calling you on day 9 and 10 when they're not feeling. They don't realize that they're not candidates for it, and then they want it. So talking about people driven by the public, I think the doctors really have to understand what Dr. Banda and Dr. Shaskis was saying, that it really needs to be given early. The patients have to come with a positive test. It was tonight somebody gave a phone call about having a rapid test, which obviously doesn't happen. In terms of my experience, I think it's very easy. We had I want to say none, but I'm so superstitious, but it was like very little side effects given. We run it over an hour. We've used both products, just depending on what we had. We usually have equal doses between them of Regeneron and Bamla, and we didn't have any side effects. We run it over an hour. We then watch them we used to watch them for 2 hours. We're watching them now for an hour after. And every one of the patients that I've administered, so that's out of the 50, I could tell you about 30 of them I'm tracking myself, and no one went to the hospital. I start out of the consensus, the consortium that I was following. About the next day, they still don't feel that well. That's the honest truth. But on the second day, they'll start to tell you, I'm not taking as much pain medicines and things of that nature. In terms of what we do, it's the same thing. We bring them in. I'm re-swabbing them. I'm not really sure why, but that's what the hospital wanted to do. I do a CAT scan, and obviously I check CRP. I'm checking D-dimer, and I'm sending them on. If the CRP is greater than 100, I'm giving them steroids. And obviously if the D-dimer is high, we're giving them Lovenox while they're there, and then we send them on Eliquis. But 2 days later, I'm starting to see the majority of patients telling me they feel better. And we're doing it through our emergency department. The criteria is very similar to what Dr. Bender was saying. Anybody over the age of 65 with a positive swab, I get a call, I'm urging them to come in. If they're 55 with any medical issues, we are doing it. There was one question that I had personally. I don't know, somebody called me and asked me if antiphospholipid antibodies in an elderly patient is a contraindication. Obviously, it's not written. The contraindication is anybody requiring oxygen, obviously, and or if it's a COPD that has an increase in his baseline of oxygen, we don't do. And another thing that we've been hesitant about is if on the CAT scan we see greater than 60% of their lung tissue infiltrated by pneumonia, we're also just shying away from it. We would give them plasma and then do remdesivir and keep them in for 5 days. It's based on our ID doc's comfort level. If it's more than about 50 or 60% of the lung tissue on a CAT scan. I have great experience with it. I think that the patients want it. I think there's a lot of education needed, both from the physician standpoint and the patient standpoint. And the key is what they've mentioned. It has to be given early. Once it's too late in the cycle, then it's counterintuitive.
Terrific. So I think that was a brief overview from 3 different providers that are using monoclonal. I think the key takeaways are that this is going to be provider driven. So providers should be aware of it, that it is an EUA. And so you should have conversations with your patients, just like anything else that's being used for COVID. While there's not long-term data, and you can't say with 100% certainty that this is perfect, or that there's nothing down the line, or that you can guarantee that they'll be fine after getting this, you can say that there's enough preliminary data that this seems to be doing something to keep people from getting really sick. And we know what COVID does as the alternative. So like anything else, it's weighing risks and benefits. And at this time, this appears to have much more benefit than risk, enough so that even the FDA has given this emergency use authorization. And providers should think about this. It might be life-saving if you can keep your patients from progressing from, the mild disease and turning into that huge inflammatory reaction and cytokine storm, which we have no way of predicting. Jack, was there, did you have other topics?
Dr. Shaka, thank you, all 3 doctors, for that. Before we get to where it's available, some providers asked a question about, since we're focused on the early phase of COVID here in this call, questions on use of steroids. Obviously, use of steroids in the inpatient setting is now well known, but maybe Dr. Shakis, you can start to address that issue.
Sure, and I think Dr. Bender might have a slide on that as well. In short, as I think, well, let's just take what Dr. Medeb just said. He talked about what his institution is doing for different patients, even around the monoclonals. And I think there's a lot of differences between the way institutions and providers are doing things all around the same concepts. Steroids currently have one study off of which a lot of it's the only study that there's any randomized data, and it's specifically for patients who are hospitalized and receiving oxygenation. If I remember the study correctly, it actually showed the most benefit in patients who were on ventilators. So the point of the matter is that we're using steroids. Providers should just realize when the right time to use them is according to the study. It doesn't mean it's right or wrong to use them earlier. There's just no data to support it. Jeff Bander, did you have a slide on steroids?
Yeah, I mean, I think again, if we were looking at, the data-driven part, you said it was the recovery trial, which looked at dexamethasone 6, which is why we're using that dosage. And, it was a big study, had a 30% reduction in morbidity for these patients. But when you looked at if you understand, again, we discussed a few times, right, the different phases of COVID. You have your first phase, which is the infectious phase when the virus is replicating into the tissues, the host tissue, and then you have the secondary phases, which are inflammatory. So really what you're treating with the steroids, theoretically, is that inflammatory phase when you have out of control immune dysfunction. Theoretically, if you're giving steroids up front early when the patient's still in the inflammatory phase, you may be actually accelerating, viral replication by decreasing host immune response. And and when you talk about the benefits of steroids, you're also talking about the downsides, which would be, the controlled diabetes, other things like that, which have bad effects on the patient. So when you look at, and again, subgroup analysis is dangerous for those who study statistics, as when studies are designed, they're not actually meant to look at it. But when you break it down, sometimes you can get information. So if you take the patients who, divided out the patients in the study who had COVID and got treated with steroids, those who were not on oxygen actually had a signal towards harm, meaning that there was no benefit in that subgroup. So if you look at where, the line here where it crosses, 1 and doesn't touch there, that means there's statistical significance. Those on oxygen, those on ventilators, clear benefit to steroids. Those not on oxygen, it crosses unity here, and so signal towards harm. So in all the hospital protocols, in fact, in order to get steroids, you need to be on oxygen. Now, I'd say sometimes we have exceptions, but as a general rule, that's sort of what we keep to, looking at the evidence that we have.
Thank you, doctors, on that. Okay, so before we take questions, I just wanted to review, there were some providers who asked, where is this available now? I'll just run through a number of the local institutions that have availability and have set up infusion centers. And then actually, I want to turn back to Dr. Medeb, if I could, just to walk the providers on the call through the actual procedure. What could people expect? How long is the turnaround time, infusion time, observation, so on and so forth. So in our area, in terms of the community hospitals that we usually access, Mount Sinai has plenty of doses on hand, has an infusion center set up, outpatient infusion center. Maimonides has an active infusion program for the MABs, and that is via their emergency department. New York Community Hospital, Dr. Medeb's institution, active infusion programs you've heard today, and available. HNMC, which is the Holy Name Medical Center of Teaneck, has plenty of doses on hand and is doing infusions in an outpatient infusion center they've set up in Teaneck. Monmouth Medical is just getting more doses as we speak and has set up an infusion program as well. We do expect other institutions to set up infusion centers, but those are available right now. They're live. You can make appointments for your patients, and we'll be circulating a memo after this call on the WhatsApp, doc chat, and other channels to make sure that you have the access information. Dr. Medeb, maybe I could just turn to you just in terms of walking people through the actual protocol and what people should expect in terms of their patients' turnaround time and procedures.
In terms of my institution, and I think majority as well as Maimonides, as we are recently partnering with them, we just require, if the person comes with a positive, we're not differentiating which labs they came from. If they come with a positive no swab, obviously PCR non-rapid, we will accept that. And if anybody calls me or in the institution emergency department with a heads up, we have a couple of negative pressure rooms already in the emergency room. Those that are not, we have isolated a certain area for. We are also trying to make as outpatient type of infusion center. I spoke to Jack and other institutions to try to do one off-site. But that being said, if they get into the emergency department and we know that they're coming, we quickly take their blood. I'm scanning them unless they had one recently, and we have the material is at their bedside within about 12 minutes. We run it over an hour. We watch them for an hour. We used to watch them for 2 hours. We shorten it to an hour and a half, and we're sending them home. Very little problems. We communicate with the primary care, telling them what they did, and to follow up, especially with the D-dimers, which is the that which I felt was the most risky of everything. It's It's really been, and the same thing that they've mentioned, we don't differentiate. Whatever the provider puts, either put Regeneron or Bamla, we're gonna give whatever there is. We don't have a preference of one over the other. Very, very rapid. We didn't have anybody with any side effects. We didn't have to give any adjuvant, no steroids or anything for reactions, no Benadryl or anything of that nature. It's been good. We've been happy with it. We've been trying to just advocate it. The only thing I would mention, Jack, that me and you got some pushback from some doctors, and I don't know if Dr. Shaskis or Dr. Bender, we have a lot of doctors who are very speculative of past data, saying that the data didn't look very good and that we shouldn't be doing it or pushing it or encouraging patients to do that. I don't know how you feel about that. We had a big pushback by me and Jack for that, saying that this is the data out. We understand that it's emergency use. This is what we have on hand. We feel that the death rate is very low anyway, now that we understand the disease better. I don't know if any doctors have pushed back to you guys about that.
Speaking for myself, I haven't heard any pushback. Patients have been amenable. I don't have other providers calling me per se, unless they're calling and asking me, how do I get my patient to get this? So I think we might be having a little bit of a bias there, that the people that are calling me at least are already ready,
Right.
willing, and able to send their patients for it. I think that's part of what tonight was about, is people should just understand what it is, and they can decide for themselves if they're comfortable or not for their patients, and at least share the data and let the patients be involved in the decision. I think there's enough there to make this a worthwhile recommendation for patients. I can say that if it was a family member of mine that had those risk factors, I would 100% be doing it. It sounds like your experience is similar, and Dr. Bander's is similar to mine as well, that we're largely seeing good results. And again, risk benefit. I feel like the risk of somebody with those risk factors progressing to COVID scares me a lot more, to that big COVID reaction, than what might happen from this infusion.
Yeah, I agree. And the reason that I pushed very hard, I think we were one of the first centers in Brooklyn to do that. And I think it's just because it's impossible. And I think this is what I keep telling Alan Esses, Jeff Beta, and Jack, is you can't treat all of Brooklyn's zip codes in New York City, in Manhattan. It's not going to work. There's not enough room. This is easy. It's given the same way. I don't think protocols are different. I don't think, it's the same IV line, same time it's running in. The effects are usually the same. So you have it local, get it, no matter what hospital you're doing here in Brooklyn or in Jersey, in Monmouth. I told the people in Deal, there's no need to schlep to the city. You have it in Monmouth, get the infusion and go home. And I think that's a key for the other doctors to understand, that it's a therapy that's been given the same way anywhere you go.
And we are still happy to give it at Mount Sinai. Somebody needs
There's a lot of community.
No, I'm not. I know you guys are great. I send you a lot of my difficult guys there. I mean, I'm just saying, I feel bad. I feel bad. I feel like it's almost cheating that everybody sends them to you, and you're getting stuck with a lot of people. And
Good. Well, we have many fine institutions. We're sending them to all the institutions I just mentioned. If there's any questions, we'd love to hear any questions right now. While people are thinking of questions, to make it easier for the providers on the call, we have volunteered a number of community health advocates and public patient advocates. So Alan Esses, thank you for volunteering, and Nancy Sutton and a few others. We'll send that around a list of their information to make it easier for you to schedule. So if you want to schedule yourself, that's fine. If you're busy, which we understand, some of the patient advocates in the community are willing to step in and help out. And we've informed the various area hospitals that they may be calling on your behalf to schedule that for your patient with your prescription for that. So are there any other questions from any of the providers on the call?
Hi, Jack, Howie Kurtz.
Hey, Howie.
Good. I have two questions, actually. The first one was the population that wasn't addressed, which generally is considered an immunocompromised population, is what is the thoughts, and I'm sure there's no studies on it, but in terms of pregnant patients. And the second question was, are we encouraging, if we have, let's say, an elderly couple and let's say the husband gets it, should the wife be testing even no symptoms for COVID a couple days later so that she can potentially get this treatment?
Well, you have to be in the EUA, you have to be symptomatic to get it. There are all of these trials for Regeneron, Eli Lilly. They're still ongoing trials for what's called post-exposure prophylaxis. So if your spouse tests positive or you're sick, and then you test, you can be enrolled in this trial even before you test positive in some of these cases and receive it as part of a randomized control trial. So you wouldn't get it, the product, you'd be randomized to receive it or not receive it. So you wouldn't know. It'd be part of a clinical trial. But we always said to people, it's 50% chance you'll get it. So it's, if you want to look at the websites, I know Sinai has one, but if you go to Regeneron and Eli Lilly, they'll tell you, what other campuses are running the trials. As far as pregnant women, Josh, I don't think it's part of the EUA.
I don't think so either. I mean, most of the patients that I've been sending have been of the older variety where pregnancy is not an issue. So it hasn't come up in my personal practice, but I don't believe it's in the EUA. It's
actually not in the EUA, yeah. So we do not administer it to pregnant women. We do give plasma to pregnant women, not pregnant people. I can say that, right? So, so we've given plasma to about 6 or 7 pregnant women at Mount Sinai without any adverse events.
Okay, I know we have Dr. Victor Grassi on it. If he has anything to add, he could just unmute himself. If not, that's fine. Okay. Oh, also, Jack, we wanted to mention it's available in Florida as well, right?
Yeah, in the list we'll be sending around, there are 3 institutions in Florida that serve our community. They all have the MABs, and they're available for slots and appointments. And we have 2 patient advocates down in Florida helping us out. So if you have a patient who's currently in Florida, you can reach out to one of the patient advocates that we have in our community to help you and the patient schedule that slot.
And I've already, it's actually been worked seamless. I had a patient of mine that moved down there, and I called a couple of guys down there, and they were able to get it. So it worked out very well.
Yeah, there's a lot of availability. Mount Sinai, Miami Beach. We have Memorial. We have Aventura. We have at least 3 major institutions that are offering it. And again, just to echo the doctors, in terms of the focus you heard from the doctors today about the early stage, getting in the first few days, the MAB centers are sensitive to that and have been really taking our appointments very quickly.
As Charles Manopla, I have one question. Is there a hard cutoff as far as the number of days of illness? I know getting to the 7 to 10 day range, you may be more into the inflammatory phase. Are centers using different cutoffs for when they won't give it past a certain number of days?
The short answer is yes. I think a key point for providers to understand is once you identify which centers you might be using, is you should understand their individual guidelines, because different centers are using let's not say variations of the EUA, but interpreting a little different and trying to make sure that they're maximizing the use of the monoclonal antibodies for patients that will truly benefit. And so that's a really good question. And there might be slight differences, mainly surrounding not the patient population that's qualifying, but at how many days the patient may be symptomatic before they would say, you know what, we're not going to consider this treatment for you any further.
Yeah, I mean, actually, when they debated this in the FDA, they wanted to really only make it 3 days because that's what the data was based on. But because it took so long to get swab results back, they realized they would knock out so many people. So in reality, it's really as early as possible.
And what cutoff are you guys using at Sinai?
5 days.
5 days.
We use 7.
Quick question here. Are any of the centers open tomorrow or Saturday?
Yes. Many of the centers we have are open 7 days a week. When you get the sheet, please call one of the patient advocates. We are keeping them informed as to all the hours of the different places. I'll let Mount Sinai and NYCH also answer right here on the call.
I have a question. Noah Gilson.
No, hold on. Sorry.
I'm sorry.
Yeah, but I have a patient. I have a patient that I think
I'm-
has been contacting somebody, a couple of centers. I don't know if anybody called them back for they were just diagnosed, an older gentleman
We'll follow up with you one-on-one right after this call, but just to answer, I believe
they
Mount
open?
Sinai, I believe Mount Sinai is closed tomorrow. Is that correct for infusion? I believe so.
To my understanding, Mount Sinai is closed.
It's closed just for the day tomorrow. Dr. Medeb, NYCH.
It's 7 days a week, 365 days a
Right.
year.
Dr. Kasky, we'll follow up with you right after this call. to
Yeah,
make sure
Ralph,
that's
I'll
the-
talk to you.
Yeah, David, just call me.
Okay.
All right, go
I
ahead.
have already 3 pending. Alan S has called me about 2 people tomorrow. We're gonna meet them and they'll give them. I'm just waiting for the final. They had a rapid. The rapid was positive, but obviously I can't do anything on a rapid.
I have a
Thank you.
question.
Go ahead.
Any data on this ultra early treatment altering natural immunity? So when a vaccine will be available, we'll have to delay 90 days to give it because of this ultra early treatment? Does
I
it
think
change
that's a
the
great-
natural
Yeah,
immunity?
so
Go ahead,
yeah,
Jeff.
there's no data on it. I think that, what they actually did was for these patients is they actually measured, cycle threshold time, which is how much virus they had in their body. So none of these patients eliminated their virus. They still were fighting off the virus. It just reduced the load of virus they were fighting. So I doubt that this is a curative form. The patients who get it as a prophylaxis, yes, probably, it might be, but no, certainly not for this. There's no reason to suspect it, but your question is very good. But we don't know the answer, but I don't think so.
Thank you.
I went for my vaccine at Sinai the other day. One of the questions they asked me was, did I receive any recent antibody treatments? I don't remember what time frame they asked me about, whether it was 30 days or 90 days, because my answer was no, so I didn't really pay much attention to the detail. But it was I believe it was one of the exclusionary criteria for the vaccine. So that's something to keep in mind.
That's the same questions too.
Yeah.
Great. Other questions, please?
We got a question in the chat if we can mention specifically by name the Florida advocates.
I think we're going to circulate that, right?
Yeah, it's Dr. Gershon Fink and Baruch. Both have volunteered to be our advocates in Florida. They've been doing a great job already, I have to say, getting many patients connected with the MAB centers. And actually making the appointments for them. So we thank our Florida advocates a lot. But it'll be in the memo. It'll be in the memo that's being circulated right after this call.
Good.
Okay, great. If there's further questions, please email us to Jeff Beta or Emily or others, and we'll get those questions to the panelists. I want to thank Dr. Schatzkis, Dr. Bander, Dr. Medeb. Thank you very much for joining us tonight. Jeff, thank you so much for organizing this, and to the SCA for organizing. And thanks again to all the advocates who are doing great work out there. Nathan Hoffman, Alan Esses, Nancy Sutton, Marie Sakaria, Dr. Gershon Fink, Baruch, all of them are doing a great job, and many more that I probably can't name right now or remember right now, doing a great job supporting the providers on this call in terms of both this issue and also others as well. Thanks everyone for joining us tonight. The recording will be available after this, and the SCA will post that. Thank you again very much for joining tonight.
Thank you, everybody.
Thank you. Thank you for having us.
God bless. God bless.